welcome to this session. I think there's a few of you here, which is great, and it's being recorded as well. So welcome to those who watch this at a later date. So welcome to this session. It's one in a series of events by the Surgical Academy, and it's aimed at CST applicants. So some of you might have come to the introductory session from Tiffany recently, and we've also got some mock interviews on the horizon as well, which we'll talk about at the end. So my name's Tony. I'm a trust grade doctor in Exeter. I've got a QI research fellow post in trauma and orthopedics. I'm actually applying for CST myself this year. So I'm going through the same process as those of you here probably, and those of you watching. So I approached the Surgical Academy. I'm on the committee, and I said I'd offer to do this talk because I'm in your shoes and I've got lots of questions about the application process. And I wanted to find out a bit more, and I wanted to share those questions and the answers with others to give all of us the best chance as possible of getting a training number. So I've asked loads of people. I've spoken to lots of different people involved in the interview process, people who've gone through it recently and in the previous years. And I've put together some slides that hopefully will be useful for all of you. If not, just a basic introduction to the process, find out a bit more and get you geared up towards February. We're joined by Sathya, who's kindly volunteered to come along as well. So Sathya is a first year core surgical trainee in Plymouth at Devon Hospital. She scored highly on her interviews last year. She's been through the process recently. She's going to offer us some insight from a first person perspective about how to approach the interview and some examples from her own interview last year. So let's crack on. Quick disclaimer, if you don't like the color blue, then it might be a long hour for you. But there's lots of blue in these slides. I think it's a great color. So we're going to carry on. So we're going to go through the application timeline. We're going to remind ourselves about important dates coming up. And you should be aware of all of these already, but it's just be a reminder and help you to get that in your head. We'll go through some generic tips and tricks for interview, and specifically online interviews as well, because as we've already established today, there's lots of issues involved in online presentations and interviews that you don't get face-to-face. We're going to talk about the interview structure, and then we're going to break it down into its two constituent parts. So that's the leadership and management part and the clinical stations. We're going to go through some examples of what you might be asked, and we're going to go through some structures, some frameworks that you can use to structure your approach and give yourself the best possible start in answering all these questions. And every little thing helps, and it will keep you calm on the day, knowing that you've prepared and you've gone through it and you've got some idea in your head about how you're going to answer their questions. So all in all, it won't take more than about an hour. I know it's a Saturday afternoon and we can get this done with and you can get out and enjoy your evening. But hopefully this and the slides, which will be shared with you later, can be a useful adjunct to your preparations for CST. So let's remind ourselves about the application timeline. So I presume that everyone here is CST applicant, or if not, you're considering it next year perhaps and just really keen. We're on this timeline. It's roughly the same most years. We've already gone through the first stage, and most of you will have received an email hopefully yesterday inviting you to upload evidence. So that's the second stage. You've got about 3 weeks to do that now. Get all your evidence together. Hopefully you've got it all nicely tucked away somewhere, and submit it. And then interviews, the invites are sent out end of January. After that, you've only really got a couple of weeks before your interviews will start. So it might seem like it's a few months in the future, it's a long time away, but actually that'll come around so quickly with Christmas, getting your evidence together, work and everything. It will come around very, very quickly. So now, today is the time, if you haven't already, to start thinking about it, preparing, getting your mind set in the right place to approach this interview. So the interview invites go out to about 1,100 people, I think, is how the applicant handbook suggests that we've done this year. It'll be a remote interview, so it's online. And there's about a 2-week period where you'll be able to attend interview. And a combination of your evidence score and also your interview score are combined to basically give you your final total score and your ranking. So the interview is an important part of the process, a really important part of the process. And there's a lot of scope to either go wrong or to do really well. So why not prepare yourself the best possible, give yourself the best possible advantage. So before we go on to talk, I just thought I'd throw this quote at you. So Benjamin Franklin, famous American inventor, scientist, businessman, quite rightly said many years ago, failing to prepare is preparing to fail. And that you can apply that to any single walk of life, any single activity that you do. Why would you not prepare yourself for this? It's a life-changing interview. You could go into this having not prepared at all and completely flop. But if you prepare, if you give yourself, if you know exactly what's going to come up, if you know how to structure your answers, then you're going to give yourself the best possible chance. It's stupid not to prepare. So we're going to give you some useful tips today that can hopefully guide you along the way. So some general advice. We all know Oriole is useless. It's notoriously bad at communicating, and your emails don't always match up with the system. There's a delay. So just be really vigilant. Check your emails regularly, but also check Oriole website, because this interview slots, when they come out, they're first come, first serve. So make sure that you get in there early and you get a slot that benefits you. So one where you're off work, maybe you've got a couple of days beforehand, you give yourself a nice time of day to prepare for it, get all set up in the morning, everything. Little things like that are really important in preparing you on the day. As soon as you have your interview slot and before, just practice. So get together with your friends, core trainees who've recently been through it, and more senior trainees as well. And just day-to-day work, just when you're presenting things, make sure you're thinking about how you would do it if you were in an interview. If you get a quiet moment, just talk with some friends and go through some questions, some examples, and see if you can. It doesn't always have to be formal, but get some mock interviews done. We'll talk later about the Surgical Academy ones, but maybe some of your supervisors or trainees at work can run that with you as well. The interviews are on MS Teams, which you probably use all the time anyway at work, but make sure that you're familiar with it, and make sure that you have a place in your home where you can set up, be comfortable, be confident, and know that there's not going to be any problems on the day. Join 5 minutes early, get your allocated time set up, have all the documents ready that you need. Just make sure that there is no interruptions at all. Be alone, shut your doorbell off, get rid of your pets, get rid of your partners, and just make sure that on the day your sole focus is the interview, because it's really important. And if you have no interruptions, then great. If you have any and it messes up your interview, it's not the interviewer's fault, it's your own fault. So there's no way of justifying that. And you might not remember, but when you submit your application, you signed a declaration, which is like a big checklist. You may or may not have read it. And it's basically, on the day of the interview, you will ensure your internet works, you're not disrupted, all sorts of things like that. So it's your responsibility. Dress smart, make sure you look like you're going to work, make sure you've got a good haircut, you shaved, whatever, and make sure that you're comfortable as well, because that's really important too. When they start asking you questions, they might try and throw curveballs, but really, if you're going down a path that you're not, they'll try and prompt you and push you back in. So if they're giving you cues, then look for them and answer them. They're probably not going to try and trip you up, because they want you to do well as well. So just respond to the situation you find yourself in. And it's always difficult. You might start rambling, but if they try and nudge you back on course, then look for that. And it's not a bad thing. Just use their advice. Some general tips for online interview. I'm probably not doing it now, actually. It's just reminded me, just look at the camera, because that's your equivalent to making eye contact. Make sure you look at the camera, not at the screen, not around the room. Make eye contact. Make sure you use the same non-verbal cues you would, like facial expressions. I'm doing some hand gestures now. Anything that you think would help in a face-to-face interview, you can do online as well. The internet connection is not always going to be perfect, so make sure you speak clearly. And if you don't hear something properly, then just ask to repeat it. It's absolutely fine to say, oh, sorry, the connection wasn't great. Can you repeat the question? There's no point you going off trying to answer a question for 3 minutes. That's a big chunk of your interview if you haven't heard it properly. So just make sure that you hear it properly. And if you mumble yourself, or if you rush your words, then they might not hear you. So just make sure that you do what you can to overcome these sometimes unavoidable complications. Right, let's get into it then. So the interview structure, it's a 20-minute interview, which is really quick, actually, considering the importance of it. 20 minutes. So it's 2 sections, but they're not separated. There's no break, and it's the same panel. So the same 3-4 people will be in front of you the entire 20 minutes, and they'll be asking you the questions. The first 10 minutes is about management and leadership, and the second 10 minutes is about clinical scenarios and clinical skills. So the management section, and you probably know all of this already, but we'll go through it again quickly. It's a pre-prepared 3-minute presentation. So when you get your invite to interview, you'll have a question that you have to prepare a quick speech for in 3 minutes, and it'll be about leadership. And you need to make sure that's nailed and slick and well-oiled. So on the day, you can just reiterate it, and then they'll ask you some questions for a couple of minutes about it. Then you'll have a management scenario question that's not pre-prepared. They'll make you think on your feet on the day, and then they'll ask you some follow-up questions as well. That's the first 10 minutes. The next 10 minutes is your clinical section. So you get 2 questions, and we'll go through and talk about what they're likely to be later on. And they ask you questions about that as well. So that's making you cope under pressure and answer their questions. The marking criteria in the applicant handbook is pretty straightforward, really. With your presentation, they're wanting good presentation skills, good content, sort of well rehearsed and well thought out answer. And then when you ask the questions, just thinking on your feet and trying to give the best possible response. The management question and the clinical scenarios, they want you to show that you can cope under pressure and prioritize your thoughts and also communicate them well and have an awareness of the kinds of ethical issues and things that we're going to discuss shortly. So the leadership and management question, like we said, there's a presentation and then there's a management scenario. The leadership presentation that you're going to have to give. So this is the one that they're going to tell you in advance, and they're going to give you a question. This is the question that came up last year, and it tends to be very similar from all the people that I've spoken to, going back as far as 10 years or so ago. You need to reflect on an experience of leadership when working as a team member. And importantly, you need to show how this will be useful as a core trainee. So this is the kind of question that you're going to get, and you're going to have 3 minutes to give a rehearsed presentation without any slides or visual cues, just your own voice, just your own enthusiasm to talk about an experience that you've had, how it relates to core training, and what you learned about yourself from it. So when we're approaching this, you're probably thinking, scratching your head, thinking, what can I talk about? So just have a think back, like in the next few weeks, go jot down some ideas, some possible ones. But we're going to talk about leadership as a general principle. And there's 3 important themes that I want you to think about as well. So leadership is change, leadership involves people, and leadership is about results. So you might get asked, and you read in all the practice textbooks and stuff like that, what's the difference between leadership and management? Well, management is sort of using the resources that you have, using them to the best of your ability, putting them all together, organizing them, and following a pathway. But normally that's a straight path that's been set in the past. It might be following guidelines or policy and just using the resources that you have to a goal. Leadership has some very similar attributes, but leadership is about setting a new direction and bringing people with you. So leadership inherently involves change, positive change. And leadership without management and vice versa are not effective. You need leadership. In order to have good leadership, you need a new direction, you need change. You need to take people with you as well. So leadership importantly involves people, involves developing those people that you work with, making their lives better, making their lives easier and their jobs easier as well. And successful leadership, of course, involves results. So you need to be able to deliver results and show that you've made positive change. So these are the things that you need to think about. In any example you use, you should have some positive change to be able to talk about. You should involve the people that were in the process, and you need to be able to give evidence that it was a positive result. So think about, later on, maybe have a look at this slide and think about some examples that you can do. So when we think about those 3 key themes, change. So change is about taking a problem and trying to solve it, or using your initiative to work around an issue. And you do that all the time. You might not realize, but all of you have done audits in the past, and an audit is like looking back through things. And hopefully if you turn that into a QI project, you've identified an issue and you've worked to solve it. So you can use that as an example. If you found issues with your training and you've raised them to your seniors or you discussed it, then that's an idea. That's an example of positive change. Change might be making decisions that impact others, and you've probably done that on a committee in uni or in your first few years of practice. Or maybe you're a representative for the hospital or the region. Those are really good examples. You could just think about how you work with people. So we said people are really important. You work with people every day. You manage opinions all the time. That might be MDT or ward round. You might be dealing with people in the office who aren't performing well or who are causing problems. It could be supporting others, working in small teams for audits or teaching. It might just be creating a good atmosphere in the workplace, organizing events outside of it, maybe your mess or something like that. These are all examples where you've worked with people to positively influence them. And that's leadership. And results, of course. You need to be able to show that you've had results. So you could talk about clinical situations with difficult patients, or difficult colleagues, but as long as you've worked through it and you've come out the other side with a positive outcome, then that's the most important thing. So we want to talk about a framework, and you've probably heard of this before, but there's this framework called S.T.A.R, S-T.A.R, and it's a really important framework. It's a structure that you can use to talk about leadership and talk about management. Situation is the S. What is the context? So very quickly set the scene for what you're about to talk about. There's no point going off on one and rambling for ages, but not having introduced the people involved or the situation or the time. T is for task. So what was the issue? What did you have to work through? What did you have to achieve? What were your goals? A is for action. So what did you do? But not just what did you do or how did you do it? Why did you do it? What was your thinking for doing it? What were you hoping to do? What resources did you work from? What inspiration did you use? So S-T-A-R, R is for results, and you need to be able to reflect as well on the process. So this framework, which you'll come across in books and talking to other people, this is a really good framework for structuring your presentation. So what you need to do in the next few weeks, you need to find an example. You need to jot down some ideas, jot down some thoughts about it, and then you need to structure it like this, S-T-A-R. And you need to practice that, practice it to other people, get feedback, trim it down, tidy it, like you're writing a paper or something. Just go through the iterations until you have a really well-rehearsed, well-oiled 3-minute presentation. And when you think about it, you're in this interview for 20 minutes. You're probably a bag of nerves at the start. This 3-minute presentation is your chance to calm yourself. It should be muscle memory. You shouldn't be trying to find the right words. In this 3 minutes, you need to just shut your eyes. Well, not shut your eyes, make eye contact, but just relax and just get it all out. Do a big pause before you start, take a breath, and then just rehearse your speech. And 3 minutes in, that's a big chunk. And if it goes smoothly, if you've practiced it and it's well rehearsed, then fantastic. Some additional tips. So just be personal, talk about yourself. Don't sell the achievements of others. This is your chance to sell yourself. So if you worked in a team, that's great, but clearly outline your role and talk about yourself and your impact. Give enough detail, but don't go overboard, particularly with clinical information. Don't go crazy with observations and this situation. Just nicely set the scene, outline the task, outline your role, and then show what skills you used and reflect on it. It might not have been, a perfect outcome, but as long as you can reflect on it and show what you learned. And really importantly, you need to be able to relate it to CST, and we'll talk about that in a sec. So then they'll ask you some follow-on questions, and they could ask you loads of different questions, but there's some things that it's good to think about. So clinical governance, which is a buzzword everyone uses all the time, but we don't really understand it. Well, I don't. So I've done a bit of reading, and this is your chance to show that you're aware of what this is. So clinical governance basically is the framework that the NHS, that we all use to be accountable for making positive change, and it's sort of controlling and monitoring and improving patient care and patient quality all the time. So it's doing the right thing for the right patient at the right time, and just using the evidence to make sure that what we're doing is correct. So there's 7 pillars, and you can read these, you can learn about these. But what I would say, and what others have said to me, is when you're in the interview, don't just say the 7 pillars of clinical governance are this, because it's boring and everyone can do that. I would say something like, I'm familiar with the 7 pillars of clinical governance, but the ones that are most important to me are audit and teaching, and then give examples of this or why you enjoy it. But there's no point you talking about IT and staff management if that's not something that you do or that you've got experience doing. So just say, clinical governance is this. I'm aware of the 7 pillars. The most important ones to me are audit and research, and then talk a bit about your audit and your research. Throughout the whole thing, throughout the whole 20-minute interview, all they're looking for is buzzwords. They want you to say the right thing and they want to hear the right thing. So you've got to do it. So this is just like some examples of words that they'll hear and they'll think, okay, yeah, good. This guy's thought about what he's saying. Words like this. So if you're using an example, just, I was open-minded about the possibilities. I was listening to my colleagues and we came up with a constructive way forward. Like all those words just sound really good. So just go on the internet if you have to and just get buzzwords for online interview, leadership, management. And then when you're jotting down all your thoughts, when you're writing your 3-minute presentation and you're practicing it, Just see if you can slot these words in. And then if you can slot them into your answers afterwards, even better. Now, part of the question was, how is this relevant for a core surgical trainee? And if you haven't already seen this document, you need to. This is the person specification. It's a couple of A4 pages, but it lists the essential and the desirable characteristics of a CST trainee. And this is vital because this is what they want you to show that you understand and can demonstrate. So all of these things. So you need to be able to communicate, problem solve. You need to have the right human qualities of a good surgical trainee. You need to be able to work under pressure and have a situational awareness. So in your answer, in all your answers, you need to relate it back to this somehow and say, so you've talked about your account of what happened and why you did it and how you did it and what you learned from it. And then you say, the skills that I showed, such as this and this, are relevant to a core trainee because the core trainee needs to be like this and this. So just be aware of this document. The link's there. When you look at the slides later, have a look. Just Google it, CST Person Specification. It's really important. Okay, so that's the first part. That's your presentation out of the way. That should be easy points in the bag because you just practiced it, you've rehearsed it. It's really slick, it's really well oiled. There's no excuse for it not to be. After that, they'll ask you a few questions about it, like we've said, and just use stuff that you've read and talked about. Use the buzzwords and try and get across that you understand the important parts of being a core surgical trainee. So the second bit is a management scenario. So they'll ask you some clinically related scenario, and they'll make it relevant to surgical practice. And it's often an ethical or a logistical issue in the workplace that you have to work through and work around. And you need to make sure that you can talk about it. So it might be something where probity is an issue. It might be a moral obligation that you have to notice and oblige to, or it might be communication situation. It could be any of these. In any situation, whatever it is, patient safety is number one. So you need to, even if it's not directly obvious, you need to identify the patient safety issue and you need to address it and say that you've considered it and thought about it. So just like we had the S.T.A.R framework for leadership and talking about experiences, in this case, we're going to use another framework that you might want to use, and it's called S.P.I.E.S, and we're going to talk about it in a sec. And that's how you structure your answer to ensure that you include all of the important aspects. So think about what you would do in the real life situation, think about what you would do in work, but also just relate it to this framework so that it's like a safety net that you haven't forgotten anything. We've got some examples here, come back to them in a sec, but we're going to talk about the structure itself. So S.P.I.E.S, so what does it stand for? Seek information. So you've got an issue, you've got a problem at work, you've got an ethical scenario. You want to understand as much about that problem as you can. So use the opportunity to ask colleagues, ask the person involved, ask next of kin, find out as much information as you can. That will make the next steps easier and will mean that you've considered it. And there might be a really simple solution, but you might not pick it up unless you've taken the effort to gather that information. So S, seek information. P is for patient safety. Like we said, this is the most important thing. Assess the risk to the patient. And if you have to, you might have to act really quickly to prevent harm. But we'll talk later about the pillars of medical ethics. So do no harm, non-malevolence, benevolence, do good. So this, you have to work out the patient situation, what you need to prioritize in order to make them safe. And that's the P. Initiative. Is there anything you can do personally right now to help the situation? If it is a small problem or a minor problem, maybe you can just do something there and then that will solve it, or you can get the ball rolling. But it's not always possible to solve things yourself, but have a think about what you can do. You might then need to escalate. So the E is for escalate. If needed, involve the appropriate colleagues or even organizations who are going to be able to help you in this situation. This is an important point, that you need to be aware of the chain of escalation. So in any situation, who would you talk to first? Who would you talk to next? And who's the very top that you would talk to? And depending on the gravity of the situation, depending on who's around, you might need to go through one or all of those people or skip some of those people. So in a smaller situation, maybe just ask your colleagues, your supervisor. If it was like a legal issue or something that you needed advice for overnight, no one was around, you might need to contact your defense union hotline or the GMC. Just be aware that these people are there and they're there to help you. And then S is for support. So you might need to support the person involved. You might need to support the wider team and support everyone at the time, or maybe even afterwards. And you're going to need your own support as well. So just show that you've considered all these things. So that's S.P.I.E.S. That's the structure that we want to use. So some examples that you might see, and this is from speaking to people who've gone through it recently in years gone by. You might have something like an angry relative who storms into the ward and says, I want to know about my mother. Why have you made her not for research? What's this? What's that? So you need to just use the skills that you've heard, like seek as much information as possible, ask who this person is, where have they come from, try and de-escalate in the process, and then think about the patient. Are they able to consent? Are they in a position where they're able to break confidentiality and things like that? So you need to consider all these things. And then you might need to escalate and get the supervisor involved. You might need to take this person to another room, find out exactly who they are and what they want to know and what they know already. And then you might need to support the patient, your colleagues. So that's one example. There's always ones where consent is an issue. So the patient needs emergency surgery, but they've got a low GCS. What do you do? And we'll talk through consent very shortly. Other ones, the classic ones that you hear in the textbook, like Jehovah's Witness comes in. You've got a drunk colleague, someone comes into work stinking of alcohol or something like that. Procedures that you might be put in a position where you're expected to do, or you're the only one around who might be able to do it, but you're not confident in doing it, or you've not been certified to do it. So what would you do in that situation? Breaking bad news, cancelling surgery, or maybe a safeguarding issue in a child or a vulnerable adult. These are common examples of things that come up. But whatever the situation is, if you have a structure framework in your mind, and I would use S.P.I.E.S, then just break it down into its constituent parts. Just be able to talk slowly confidently about what you would do and who you would speak to. And it's worth just going through these examples and seeing, is there any like little caveats or special points that you can consider? Like for Jehovah's Witnesses, there is actually a hotline that you can access probably through the internet, and it gives the up-to-date latest guidelines on what Jehovah's Witnesses would and wouldn't accept in certain situations. So that might be one that you can reach. Or some Jehovah's Witnesses carry a card and it has an advanced directive about what they would do in certain situations. So just to know about this is useful, to know about your GMC and your defense union hotline and all sorts of stuff like that, stuff that you've got up your sleeve in case they ask you. Consent and capacity is quite likely to come up. It's a recurring theme, and particularly in surgical practice. So you need to know a little bit about it. You need to know about the consent process, and it is a process. It's not just a one-off signing a form, 1 minute thing. It's about sharing information with the patient, going through a journey, particularly if it's elective surgery, making sure they're aware of all the steps involved and giving them the opportunity to ask questions and to find out as much information as possible about the procedure. If a patient lacks capacity, then that's a slightly different situation, because you might need to make a decision in their best interests. It's always preferable to involve the patient, but it's not always possible. So in that situation, you'd make a decision using respect, dignity, and not discriminating about the patient's best interests. But do always consider, is there an advanced directive? Have they got legal representatives or next of kin who could help inform the situation? Is the lack of capacity going to be permanent, or is it going to be temporary? Have they got a diagnosis of dementia, or is it just delirium or something like that? And it's important to know that consent for an procedure or consent for anything is a time and procedure specific thing. So someone can consent to having their blood pressure taken on the ward, but they might not be able to consent to having an operation the next day. So you need to consider everything as a specific entity within itself. And without an advanced directive, that decision sometimes comes down to the medical team. But you always need to make sure that you've used as many parties, as many people to get consensus. And there will be situations where not everyone agrees, and this is where you need to know where to look to. So experienced colleagues, if needed, legal services, independent advocates, things like that. Mental capacity is a slightly different issue, which you'll deal with all the time on the wards, but definitely read up about that too. A few other things that it's worth reading. So Gillick competence might come up. So you might be familiar with that, but in children under the age of 16, sometimes they can be able to give consent themselves without parental input if they satisfy certain criteria. So if they're able to understand the decision and retain that information, communicate it, know the consequence of their actions. Fraser guidelines are similar, but specific to contraception and can be extended to abortion as well. So it's worth knowing about them. It's always worth knowing about the pillars of medical ethics: autonomy, beneficence, non-maleficence, and justice. And these are buzzwords. Like we said, buzzwords are so important. Try and squeeze them into your answer if you can. It will just set you apart from others who might talk about it, but not actually say the words. So make sure you get that in there if you can. In surgery, the WHO checklist is massively important. And, people might say that, but what would set you apart is saying, I'm aware of the WHO checklist. So it was introduced by Atul Gawande, who was a prominent surgeon and took inspiration from the aviation industry to create a checklist that we use every day throughout the patient's journey to and from theatre. And it's really important because it reduces the chance of never events and it makes sure that the whole team is on the same page. So just be able to talk about stuff like that if you needed to. It's important to know about types of consent form. We've already spoken about consent. If you were to talk about that, don't just list them. Say, I know the consent process is a process. And then it will lead you on to say there's type 1 consent or there's type 4 consent. Those are the most common ones. And just be able to talk about it because it'd be really useful. And then be aware of never events. You might have seen them. You might have been involved in them. You might be able to reflect on an experience you've had, but know why they are never events and know what you would need to do in a situation that one occurred. Who would you talk to? And again, buzzwords, things like duty of candor. So if something happened that was avoidable and significant, it would be your duty to then let the patient know that it's happened and offer them support and offer them a chance to discuss it if they needed to. Cool. So that's the first part of your interview. That's the first half, the first 10 minutes. I'm going to pass you over now to Sathya, who's going to talk to you about clinical station, which is really important in the second half of your interview.
Oh, thank you, Tony. So yeah, as Tony mentioned, the second half of the interview is the clinical station. People tend to think that the management station is normally the hardest one because they tend to be not sure what the topics that's going to come up in the management station. But if you do look at the final mark sheets, people tend to do a little bad on their clinical stations compared to their management, because they're overconfident in themselves that they've not practiced well. There are a few pitfalls that people tend to do, or mistakes, a few mistakes that they normally tend to make, which we will discuss in the upcoming few slides. As Tony mentioned, again, this is a 10-minute station, which contains 2 scenarios, normally 5 minutes each, and your interviewers, there are going to be 2, with an impartial person sitting there just to make sure that the interviewers are not doing anything out of the book, if you may, or not being discriminative of or doing that something that they're not being expected to do during your interview. So they're not, the third person is not there to look how you're performing, but they are more involved at looking at the interviewer's performance. These interviewers, they're going to take turns asking you questions, the ones, and also they're going to take turns marking you for your questions asked. Even if you have to go through the same answer again, which you will have to for your A2E assessment, as we will speak in a second, you will have to run through the A2E assessment in a repeated manner. But you will get points for repeating the same buzzwords, for saying that you're going to assess the patient's airway or the patient's circulation, and for you saying that I will establish a patient's IVF access. You will get points for these in both of the scenarios. But it's going to be a little awkward repeating yourself. This is one place where people tend to stumble and just be like, oh, I've already mentioned it. Is there a point of mentioning this again? And just bypass so many marks that you can easily get by yourself. So the 2 scenarios, one's going to be trauma-based, usually a patient who arrives in the ED with a road traffic accident or fallen off a trampoline or fallen off a ladder, a thing as such, or while they were in the hospital, they've had a fall and now they're complaining of a hip pain or a chest pain. And the other situation's going to be a critically unwell surgical patient, where you will have to face them with your CRISP course moulage hat on. You will have to go through the A2E assessment, as I've mentioned, in both these scenarios. In each scenario, once you're being asked the question, you will then be given 5 minutes. Within these 5 minutes, make sure that your answer, the A2E assessment, is about 3 minutes, and you leave enough room for your interviewers to ask you follow-up questions about any of the comments that you made or any of the further management or investigation plans that they need. Within the first 3 minutes of your answer, do not let them prompt you for basic A2E things. Do not let them prompt you asking what's going to be after your airway assessment. Okay, what comes after circulation? Do not let them ask these things. These are easy points. These should not be missed points in your interview. As Tony mentioned in his part, the management, you can be prepared for your speech that you're going to pre-make and go to the day of the interview, but also you can make sure that you're pre-prepared for your A2E assessment as well. You need to practice, practice, practice. I cannot emphasize enough how many times you've got to practice with yourself, using your camera, MS Teams or Zoom. Record yourself, practice in front of a mirror, practice with friends who are going to be sitting or facing the interview. Practice with core surgical trainees, especially the CT ones, who's just about finished their interviews and just settling into their roles. Get them to do an example answer, how they performed in the interview, and try to see what points you can take into your answer from theirs. As I've mentioned, I cannot repeat this enough. It is quite awkward to say the same answer twice, but they do expect it. And as they have allocated a chunk of marks for you to be a thorough person who's quite methodical in their systematic approach every time they look at a patient or assess a critically unwell or a trauma patient. You're not expected as a core surgical trainee to do complex surgery or anything, but you will be expected to know how to do a proper management and simultaneously resuscitate a patient who's critically unwell or a trauma patient. Don't have to go into the minuscule details that you might actually do in real life. Just make sure that you broadly cover your A2E approach. Let's look at the ATLS course scenario first and how you might be able to face if you're given a question with the ATLS scenario. Just say, when they pose you the question, and then start the timer. Do not jump the gun and just answer right away. Just take a few seconds to yourself. Think whether you're answering the correct scenario. Do not give a crisp answer to the ATLS question. Think a second, try and relate all the answers that you give to the patient that's concerned in your question. Say that you would assess this patient according to the A2E protocol as per ATLS guidelines, and that you would resuscitate the patient while you simultaneously assess them. Say that you would ask for help, put out a trauma call. Say in the primary survey that you would assess for the airway and the C-spine. That you would talk to the patient, establish their airway is patent, and ensure that their C-spine is stabilized. You don't have to go into the details of how you would stabilize the airway with the triple manual or with an airway adjunct, unless they actually ask and probe you into giving the answers. These are minuscule things that you can leave out and then move on to, say, breathing. Say that you would assess the patient's breathing with look, listen, look, feel, listen approach. That you would look for any obvious chest wounds, any deformities, that you would feel for a central trachea, equal chest expansions. Say that you would assess the patient's heart and lung sounds. Look at the patient's respirate, the saturations, and hook the patient into 3 leads monitoring. Say that you would apply the patient some high flow oxygen via non-rebreather face mask, and that then you would move on to circulation. When you finish one segment, like the airway segment, the breathing segment, the circulation segment, clearly mention that you've completed the one before, and then you're moving on to the next one. Because each of these carries separate chunks of marks that you can collect on your way. Say that you would, in the blood, in the circulation, you would check for the blood pressure, pulse rate, capillary refill, look whether there is any obvious bleeding, whether the patient's got warm peripheries, and that you would establish large bore IV access, and that you would take some bloods. Because this is a trauma situation, you would need some full blood count, look at the HP, some U's and E's, kidney functions, to look at their clotting profile before you give anything, any blood products to them. Say that you would cross-match just in case the patient wants to go to the theatre, has to go to the theatre, that you would keep a few cross-matched blood saved as well. Say that you would look at the VBG to look at the lactate levels, because it gives easy answers to most of the patients who's losing blood or coming to the ED with trauma. Next, with the established IV cannulae, that you would give them some fluid boluses, preferably IV crystalloids, say sodium chloride 500 milliliters bolus, until blood is available. Remember, blood to blood in a trauma situation. If they want to ask you about a massive transfusion protocol, they might interrupt you here and ask about that. Be confident. Don't be swayed simply because they interrupted your answer. They're trying to get the best out of you and direct you towards your patient's further management plan. Then say that you move on to the disability where you would check the patient's blood sugar, the patient's GCS with the AFPO score or the GCS score, whether the patient's hypo or hyperthermic. In the exposure and everything else, if you have not managed to mention anything that the patient's coming in with, this is your chance to shine in the exposure and everything else level. Say that the patient's coming in with a trauma to their abdomen, mention that you would do an abdominal examination at this point. Suppose a patient's coming in with a supracondylar fracture of the humerus, complaining of a pulseless arm. This is where you have to talk about the hand, arm, forearm examination. If they're coming in with paralyzed lower limbs because of a trauma, say that you would do a long bone examination, a pelvic examination, a log roll, and a spine examination as well. These things need to be addressed here, and say what your resuscitative measures are going to be. At the end, use this buzzword, say I would reassess my patient, and if the patient's still unstable, I would ensure that the patient's stable. At this level, try to take a breather, try to assess what your interviewers' feedback's going to be, whether they've the blank face, looking at you, thinking you've got to say more, then carry on, talk about your secondary survey, head-to-toe examination, and an ample history taking. But if they do ask you questions, do not interrupt them and talk about the secondary survey and adjuncts or what next gonna be. Let them ask you the question. Incorporate all these secondary things into your answer while they ask you the questions. If they ask about what investigations are you gonna perform, then you can talk about all the adjuncts, including the imaging, whether it's gonna be a trauma CT scan or a chest X-ray. If they ask about criteria for a patient who's coming in with a head trauma, what would warrant them to have a head CT scan within a certain number of hours once they've presented to DT. Talk about that. Talk how you would establish that the patient's got proper urine output with a catheter, an NG tube, to decompress their stomach if it's necessary. Show that you're human. Give the patient some analgesics. If it's necessary, start the patient on antibiotics if they've got an open wound. Give them tetanus toxoid, the tranexamic acid, which is quite essential in a hemorrhagic protocol in a trauma patient. Say that you would review the ambulance notes, the medication charts. You're trying to get a place in your core surgical training. You're a surgeon. Make sure that the patient's theatre ready at any given time. So keep the patient nail by mouth tentatively until you figure out what's wrong with the man or the woman. Escalate to the seniors appropriately. This is going to contain marks. Make sure you escalate to the ED seniors if you're in the ED, or to your own surgical team. You need to talk to the theatre staff if the patient is going to the theatres, or if tentatively you need to let them know. Or if you're talking about a patient who might go to the theatre now or needs an airway establishment, you need to talk to your anaesthetic staff. If they're critically unwell, you might need to talk to the ITU people as well, or your ITU registrar, to escalate promptly. But also know your limitations in the ATLS scenario. You might be in a tertiary hospital, but you might also be in a hospital where the patient needs to go for a transfer. Make sure that you mention them, how you would make them transfer ready or transfer safe. Say you would accompany the patient because the patient's got a tube down their throat, that say the patient's coming in with burns and they need to be transferred to a burns unit. Then they might ask what the indications are for a transfer for a burn, for an adult, a child, how you're going to fluid resuscitate, and how you would make sure that the patient's stable enough for a transfer. Say that you would intubate them tentatively just to make sure that their airway doesn't collapse. These are important things. Once you've now conquered your ATLS scenario, they will give you the CSP scenario. This is likely going to be a patient who's going to come into your ED with an acute abdomen or problem with their urinary system, with an obstructed, infected system, or a patient who's been in the hospital for a while, now who requires your urgent attention because they've clinically deteriorated while they were in the ward. They could be pre-op or they could be post-op. This is not too different from your ATLS answer. Again, you'll have to go through that awkward situation where you tell the same answer of HV assessment to the two people who's been listening to you for the last 5 minutes. Don't worry, you've got marks to conquer. Give the same answer, but make sure that this is CRISP ready rather than trauma specific. Instead of a trauma call, you would put out a med call, ask for help from your ward staff. In the bloods, usually these patients are septic, so you need to include a CRP, a LFT, a blood culture, and say a VBG to look at the lactate levels. Here in the circulation, bring in the sepsis 6, bring it fast and talk about it, take it out of your way. Mention that you've already given them oxygen, you've already given them fluids. Say that you would give them antibiotics according to the hospital guidelines. Say that you've taken bloods for blood culture, you've taken the lactates via VBG, but also mention that you would like to catheterize the patient, take urine output for fluid balancing, and also for some urine samples. In the secondary survey, here if the patients, if they've had a surgery, review their op notes, review their obs chart if they've been in the hospital, see how their obs have been behaving. Look at the fluid balance chart. If you mention this, you might get some positive findings from the interviewers, so you could progress in your answer. Examination of the source of problem could come in exposure and everything else. Do an abdominal examination for a post-op patient who's had a laparotomy. Do a patient who's presenting with a septic joint, a joint examination in look, feel, move approach. You will get points for these, but be confident in your answer. We'll next look at a few topics that could easily come up in your interview. Any of these questions or any of these topics could potentially come in your interview. You need to be prepared for any of these in case it gets asked from you. I suggest that you take a screenshot of this and tick yourself as you read them. Make sure that you know at least a few investigations, a few management options that you could initiate or establish, or what their management goals are going to be if these topics come up following your CRISP or your trauma question. Tony, the next one. We'll run through 2 examples. So in the question 1, this is a trauma question where you're a CT1 in trauma and orthopedics, where you've been asked to review a 5-year-old girl who's fallen off a trampoline and presenting with a supracondylar fracture of the elbow. She's now got a pulseless forearm. When they ask you how you would manage this patient, because this is such a tailor-made question, a pediatric trauma, you might get thrown off a bit as soon as they ask you the question. Don't worry, you've already got 3 minutes of your arms covered. Just tailor make it to this patient. Essentially, talk about this 5-year-old girl. Talk about your A2E assessment, but also in the exposure and everything else. Talk about the arm examination, how you would do a motor sensory examination, how you would do a vascular, peripheral vascular system examination to ensure that the arm's fine. Because you need to ensure that the resuscitative measures are being taken. Say that you would put the arm in a plaster cast to reduce the pain and to ensure the blood supply is okay. Here, the escalation also needs to go via your pediatric team or the pediatric trauma team. Involve the patient's family first, the parents first. If they talk about a child, they are asking you to think about non-accidental injury. At least you need to mention, even though it seems like a very clear cut, very straightforward kind of a presentation, mention that you would think about non-accidental injury and exclude that as well. If you think about the second question, which is a CST scenario, you've been called down to the ED to review a diabetic 78-year-old man who's presenting with a right upper quadrant pain, jaundice and a fever. You know this triad already. It is acute cholangitis, need to ring bells in your head by now, with low BP, tachycardia, high temperatures, high respiratory rates, near normal saturations on air. They would be asking you how to proceed. Even though this would be jumping straight at your face, just don't start talking about the exact management of cholangitis. Nobody wants to know that. They want to see how you would manage this critically unwell surgical patient. Go through your A2E in exposure and everything else. Talk about how you would manage the patient's abdomen. At this point, they might disrupt your answer or just intervene and ask you specific questions, what your differentials are going to be. Talk about cholangitis, talk about other possibilities like an acute cholecystitis with a superadded another infection. Think about the patient's age, a 78-year-old man, bells again with jaundice, could be an adenocarcinoma with a superadded infection. Mention things that you would talk to your consultant about. Get all the possible points that's up for grabs. I'm sure you're all going to do fantastically well. If you've got any questions, you can stay tuned until the end, but I would hand my mic back over to Tony. Thank you.
Thanks very much. Yeah, that was great. That was really thorough. Structured approach to the clinical scenario. So we've covered the management leadership presentation, we've covered some ethical scenarios that they might ask you, and then we've covered the clinical scenarios as well. So in summary, basically, you need to know what to expect. We need to know what's going to come up, and it is the same every single year by and large, with the same structured questions. And like Sathya said, you might need to repeat yourself for the clinical scenarios. You might need to say all the obvious things and then go on to say the stuff that will set you apart and the stuff that you've read around and prepared. So know what to expect. Practice loads. Practice. There is literally no substitute for practice. So just practice, basically, particularly your rehearsed presentation for 3 minutes, because there is no excuse for not having that down to a T. Revise your clinical topics. I mean, you need to do this. You absolutely need to do this, because if you get stranded with a question that you don't know anything about, then you can fall back on your structure and you will get marks. But in order to get top marks, you need to know at least a bit about each of the pathologies that we've suggested might come up. You might be preparing for exams anyway, so it's all useful. It's all useful practice. Just make sure you don't waffle. So have a structured approach in your head. The time is so short, like 20 minutes is not a lot of time at all. So get across what you need to. If you need to do a brief introduction to your comment, then do it, and then go on and then summarize. Don't waffle, definitely don't waffle. It's very easily done, and you'd hope that they would nudge you back on track, but they might not. So just be cautious. Test your internet connection, your computer, your environment, do all of this in advance. Make sure you've got working speakers, make sure you've got a microphone that works, because there's no excuse for not having it on the day. And make sure on the day you're as prepared as possible. But most important, be concise, be confident, and sell yourself. This is your chance to really show what you're about, and this is your only chance to have a human interaction in the whole process applying for CST. And it does seem like a robotic, it seems like there's so many hurdles and everything. So this is actually your chance to show your personal skills and your personal qualities. So make sure you take advantage of that, because you might not have as many research papers as the next person, but if you can actually communicate well in a situation where they're asking you questions, if you can smile and if you can get across your own personality at least a tiny bit, then it might well make you so much more appointable than someone who's got 10 research papers but just can't handle an interview. So there is still that element. Fortunately, it's not face-to-face, but an online has its own quirks, and you just got to work around them and make sure that you do the best you can. So everyone's going to be absolutely fine. Sure, the fact you're here means you're keen, you've got this far, so just keep going with the hard work, keep preparing. Some other useful resources. So the book in the middle is one that's slightly more generic, interview skills. It's got some medical questions and stuff, but there is some useful topics in there. I've used that in preparing this speech as well. So in this presentation, the one on the left is surgery specific, and it's really good, and you should be able to get it out of your hospital library. Get in there early because there's probably not many copies.
Just to mention the core surgical interview book there, it is an older version, so it talks about the face-to-face interviews that they used to have with where you had to take your own paper portfolio and talk about them as well. So skip those parts, just maybe focus on the clinical topics and the management topics that you can find in there. Sorry.
No, that's good point. And there's websites as well, core surgery interview, all these ones, just Google it. Medibuddy, I think some of them you have to pay a subscription. May or may not be worth it for you, depending on what other resources you've got, but they're there, they're out there, and there's no shortage of preparation that you can do. So, and of course, Surgical Academy, so we're putting on some other